So here we'll talk a little bit about technical issues, indications, applications, and some limitations of coronary CTA. So here's a conventional catheter angiography here. Very nice delineation of the vessels, right? Very nice resolution. So here they're injecting the left main. It's right into a right projection. So what's the problems with using that for diagnosis of coronary artery disease? Well, it is an invasive procedure, has a complication rate, even though it is low. There is a low mortality rate, quite low mortality that is associated with that. The major problem, though, is if you're using it for diagnosis, up to 40% are negative for significant coronary artery disease. So the patient would have a cardiac cath, but there would be nothing that they would find that requires intervention. So the idea is to, if you're going to send a patient for an invasive procedure, you want to send them for a procedure where they're going to do something like put in a stent or find something that's going to require, more likely to require treatment rather than a negative study where they're not going to be doing any treatment. Another problem is that coronary catheter angiography only looks at the lumen of the vessel, and that can be deceiving. So if you have, let's say, a very complicated plaque like this, right? When you're looking at two-dimensional projections of this, it can be hard to tell or that, how severely stenosed that this vessel is, because all you see is the contrast, and you'll see the contrast around that, and if you happen to get those two views, you're severely going to underestimate the degree of stenosis here. Similarly, if you have a really severely ulcerated plaque like this, and then you get the contrast within the crevices, again, you're going to severely underestimate the severity of that. And so all these limitations come from looking at just the lumen of the vessel on 2D projections. And then we talked about this also, is that you get remodeling as plaque grows away from the vessel when it grows in the wall like that. And so again, you're underestimating the severity of the atherosclerotic disease because all you see on angiography is a lumen there, and you have no idea about how severe the atherosclerotic disease is actually within the wall of the vessel. A way to actually evaluate the plaque is with intravascular ultrasound, so they can actually put an ultrasound device into the coronary artery, and then there you can actually image the plaque, the characteristics of the plaque, whether it's a soft plaque or a hard plaque also, based on the echogenicity from ultrasound. But again, it's a very invasive procedure if you want to use it for evaluating plaques. So the advantage with CT is that not only can you look at the lumen of the vessel, but you can also look at the vessel wall. So the expression here is you want to evaluate that the angiography just sees the hole, but you want to evaluate the donut. Not only the lumen, but also the wall of the vessel, which is the advantage of CT angiography. And so what are the considerations that go into the ability to generate a diagnostic coronary CT? So that's the topic of what we're going to discuss here. What do you have to know to be able to do this? So these are the issues that we'll talk about as we go through this. Spatial resolution. First, we're looking at very small vessels. So if we look at, what kind of spatial resolution do we have? Electron beam CT, which was first used also for coronary arteries, has a spatial resolution of 3 millimeters. And then as we get to 64 slice CT, we get down on the order of 0.6 and 0.4. Cardiac cath still has the best spatial resolution, 0.2. So cardiac CT still does not approach the spatial resolution of cardiac cath. But when we're doing CT, what is the most important determination for spatial resolution if we're doing cardiac CT? What is the determinant of spatial resolution for cardiac CT?
Movement of the heart?
No. Slice thickness. Right. The slice thickness is what's important. Because you're going to do multi-planar reformatted imaging. You're going to reformat the image along the plane of the vessel in curved reformats. And then there your limitation as to the resolution in those different planes becomes the slice thickness. You can have a thick slice and very good resolution within the plane of the slice, but once you try to reformat that into different planes, then the image can get blocky, right? So that's why the slice thickness is the most important determinant for spatial resolution. So here's a model of a coronary artery with various types of plaques, lipid, fibrous, calcified. Here, tiny calcifications there. Here's a stent with simulating atherosclerotic disease there within the stent. So you can see what does the resolution look like on a 1 millimeter slice, right? And then here's a 0.75 millimeter slice, and here's a 0.25 millimeter slice. So it's here at the very extremely thin slices where you can actually start to resolve the obstruction, or how bad the obstruction is inside of the stent. But when you take your axial images and reformat them along the plane of the vessel, it's the slice thickness that becomes the limiting factor for your spatial resolution. So you can think about this if you think about a picture in a newspaper. If you hold up a magnifying glass to that, it's made up of a bunch of really small dots, right? Those are the pixels that make up the picture. So same thing is true of a CT, right? It's made up of these small little squares, and they have a certain dimension. So here it's 0.5 by 0.5. But there's also, along the z-axis, a thickness along the axial direction. And if the resolution along the axial direction approaches the resolution in plane, then you have an isotropic imaging voxel here. And what that means is, regardless of how you reformat that image, any plane, sagittal, coronal, or curved reformatting, that there is no loss of resolution. Okay, so here are nice curved reformats of the coronary vessels, which is what we like to look at. And it's also three-dimensional information when we do this, okay? So that's why you can develop these three-dimensional models, the volume rendered imaging, and then look at the course of the vessel and spin it around any way you want.
Did you make this video, Dr. Melton?
Well, hard to do. Okay, your problems are motion. There's breathing motion and cardiac motion, so that's what's going to interfere with your ability to image. So how do we take care of breathing motion? We ask the patient to hold their breath, right? And so now with 64 slice CT, you can do the scan in less than 10 seconds, okay? So that means that the breath hold is not so much of an issue, especially for outpatients, right? When we're doing this to take care of breathing motion. Now, what about your coverage? So here's a comparison of 64 slice CT and 320 slice CT. So the spatial resolution is comparable, but the coverage is different. When you have a 64 slice CT scanner, every time the gantry goes around, you can only cover 4 centimeters of anatomy each time the gantry goes around, which means that if you're going to cover a heart that may take 16 centimeters, you're going to have to go around 4 times, okay? Now the problem with that is each of these different areas was taken with a different acquisition, and one of the problems is what they call this stitching artifact. So if there's any motion between one acquisition and the next, if the patient moves, if the heartbeat is not exactly the same, then you can get this misregistration, or what they call a stitching artifact between one acquisition and the next. That's what can happen with a 64 slice CT. When you get a CT scanner that has more slices and it can cover the heart, then instead of 4 or 5 heartbeats, right, because each 64 slices here is a different heartbeat, but if you have 320 slices, you can cover the whole heart now in 1 heartbeat. So there is no longer any of that stitching artifact. The whole heart has been acquired in 1 rotation of the gantry. So that decreases the number of artifacts that you have. The disadvantage over here is the cost, right? They could cost up to 3 times the amount that a 64 slice scanner would cost you. Next issue is shutter speed. So what does this mean? Temporal resolution shutter speed. How much time, if we have, remember, we take our images on CT and break them down 1 image at a time. How much time does that image represent? Okay. And so here's a pendulum that's moving back and forth, and we have pictures of it using different shutter speeds. Here's a very long shutter speed. Here's a very short shutter speed. So you can see that if this picture represents 750 milliseconds, that there's a lot of blurring, there's motion artifact there. Whereas over here, if you have a very short shutter speed, now you can freeze the motion. So the same thing is true because we can't stop the heart from beating, you don't want to, so the heart is always moving, right? So you want to avoid the blurriness and the motion of the heart, and so you do that by improving your temporal resolution, okay? So what determines the temporal resolution of CT? If we're going to image the coronary arteries, and then the correlate of that is, well, how can we improve the temporal resolution if we have to? So what determines the temporal? So you understand what I'm saying, right? If you get a CT image, that image represents a certain amount of time, right? What determines that amount of time?
The gantry revolution?
Okay, so the best temporal resolution for CT is what? When you're talking about, so you're talking about rotation of the gantry.
Right, if you just do it in one rotation?
Actually less, but that's an important point, right? Because you only need 180 degrees worth of data from CT to generate an image. Above 180 degrees, you get redundant projections. So usually when you're doing body CT, you are rotating the gantry 360 degrees because temporal resolution is not so important there when you're imaging the liver and the body. But when you're imaging the heart, we want the best temporal resolution, so then that is done with a half rotation of the gantry. Okay, so the information is acquired, only the information acquired in 180 degrees of rotation is used to generate the image. Okay, so the temporal resolution for a CT scan is one, or the best temporal resolution you can get is 1/2 of the rotation time. Because with 1/2 of the rotation, that gives you enough views to generate the data that you need to be able to generate your image. And so here's kind of an example of that. So as the gantry goes around, here's what the image looks like. Once it goes around 180 degrees, now we have enough views to generate a diagnostic image. Okay, so the temporal resolution, the best temporal resolution that you can get is 1/2 of the rotation time. So what can you do to improve the temporal? Well, you can make it rotate faster, right? But the problem there is engineering. At some point it flies off and hits the wall. That doesn't work. But there is something else that you might be able to do that some scanners have now that you can also buy for twice the cost of it.
Add a little red guy that spins around. An extra source.
So add an extra source, right? So those are called dual source scanners. Okay. So when we talk about temporal resolution here, so 64 slice CT, the temporal resolution is about 165 milliseconds. Cardiac cath still has the best temporal resolution, 20 milliseconds. So the temporal resolution of cardiac CT is far better, of cardiac cath is far better than CT. An electron beam CT, which they used to use for cardiac imaging, still has better resolution than multi-slice CT, but this has other technical problems like you're limited as to slice thickness there. So if you have two sources though, two tubes at 90 degrees to each other, right? Then you only need 180 degrees of data, so that means that each tube only has to move 90 degrees to get you your 180 degrees of data. And so then your temporal resolution becomes 1/4 of the rotation time, okay? So dual source scanners, this is why dual source scanners are prized for cardiac imaging, because that gives you the best temporal resolution that is available now on the market for if you're going to do cardiac CT, okay? Cardiac gating is very important because you get your information, but you need to be able to acquire it at a precise point in the cardiac cycle to generate images that don't have artifacts. So the first thing you have to do is you have to make sure that you have good cardiac gating. So you set up the leads, you check it, make sure that your cardiac gating is good before you actually do the examination. Now there's different types of cardiac gating that we use for CT. There's prospective and retrospective, so what's the difference and what are the advantages and disadvantages of each? So what is prospective cardiac gating?
You are
You're imaging at a certain part of the cardiac cycle?
Yeah, so you're imaging at a pre-selected point in time within the cardiac cycle, and so you're limited to that particular part of the cardiac cycle, okay? So the advantage of that is what?
Less dose.
Less dose, right? And the disadvantage is
You only see one part of the
you
cardiac
only
cycle.
see one part of the cardiac cycle, right? As opposed to retrospective gating, which is what?
Scan the whole time and then
Scanning,
go back.
right, scanning the entire cardiac cycle. Of course, that gives you more dose, but the advantage there is you do see the whole cycle. So with prospective gating, usually we scan in diastole, okay, because that's when the heart is moving the least, when you're looking at the coronary arteries. And so prospective gating, you would scan during diastole here. And then if we're doing prospective gating, we scan, get your 64 slices, this is assuming 64 slice scanner, and then the table moves to the next position, and then you scan at the next position. So this is kind of a point and shoot technique, right? Where you scan, table moves at the next heartbeat, and then at the heartbeat after that, you acquire your next scan, okay? So the table has to move in between the heartbeats. And we can only reconstruct the images that were obtained during that phase. As opposed to retrospective gating, so here you scan throughout the cardiac cycle, the X-ray tube is always on, and then here the table is moving continuously. So this is acquired with a helical technique for retrospective cardiac gating. But you have all the information throughout the cardiac cycle, so you can reconstruct any part of the cardiac cycle that you want to look at. So you can use this for functional information if you want to look at systole and diastole and figure out cardiac outputs. So prospective gating is lower dose, retrospective higher dose. You need regular heart rate for prospective gating. You need to be able to predict when the next heartbeat is going to be. If you have an arrhythmia, then you would prefer to use retrospective gating because you can do ECG editing. We'll talk about that in a second. There's a lot of redundant data when you do retrospective gating. You can erase an irregular heartbeat from your data set. You can only reconstruct the phase that you scanned at in prospective. You can reconstruct any phase in retrospective. And this is a sequential scan, meaning that you point and shoot, acquire your images, table moves, acquire your next set, whereas this is with a helical scan. So here's a case where the patient had an arrhythmia during the scan, and so that creates this artifact here, okay? So what you can do is, if you've done a retrospectively gated scan, is you can go back and you can erase the abnormal heartbeat from the data set. There is enough redundant data in a retrospective CT that you can do that, and then you remove the artifact from the image, okay? Now, you can't do that with prospective gating. You're stuck with what you get, okay? Now, as far as the reconstructive method, usually what we do is we break up the RR intervals into percentages, right? So there's 50%, 10, 20, 30, 40, all the way to 100 is your next R wave. And so usually if you're reconstructing your images for coronary CT, around 70 to 75% of the RR interval is usually where we reconstruct our images. Because first, you want to be in diastole, and second, you want to be away from this guy. What is that guy? P wave. Why do you want to be away from that?
The atrial contraction.
That's where you get atrial contraction, right? So that introduces motion into the image, right? So that's why we tend to reconstruct in that range there, about 70, 75% is where you like to start. There's another way to do it actually using the, time, it's absolute milliseconds between R waves, but usually we do it as a percentage, okay? Now, if you're doing it as a retrospective gated scan and acquiring it helically, then the pitch has to be adjusted to the heart rate to make sure that you scan all parts of the heart correctly. Fortunately, all of that is done by the computer itself, so it's not something that you need to worry about, okay? Because there can be gaps in the data if your pitch is too high. So I'm sure you're all familiar with pitch and what it means. So at a 64 slice CT, we're scanning 4 slabs of anatomy every time the gantry goes around, right? And so if if you have a pitch of 1, there's no overlap and no gap. If you have a pitch of 1.5, there is a gap. This you do not want when you're doing cardiac CT. So usually, though, we use a very low pitch, around 0.3. So there's a lot of overlap between one rotation and the next if you're doing retrospective gating. And that's what gives you enough redundant data when you're doing retrospective gated CT. So this is an image that you also generate when you're doing cardiac CT. So it's telling you when the X-ray tube was on here, and then here you're looking at the ECG. So if I tell you that, well, it is retrospective gated, right? You can see that the X-ray tube was on for the whole scan. If the heart rate is 60 beats per minute, what was the breath hold time?
6 seconds.
Yeah, so you see 1, 2, 3, 4, 5, a little bit more than 5, maybe 6 seconds, right? So you're right, because that's how much time. Really I'm asking about the scan time here. So how long did this scan take? 1, 2, 3, 4, 5, a little more than 5 seconds, right, to scan the whole heart. That's what a retrospectively gated study. Now here's a prospective gated study. Again, heart rate is 60 beats per minute. So here, how long did the scan take?
3 seconds.
Well, like same thing, right? Like 6 seconds or something?
Well, let's see. 1, 2, 3, 4, 5, 6, almost 7, right? So what happens here is that the table has to move, right? So here the table moves in between, and that's why we're not scanning. So the table moves to the new position. Now the patient has to hold their breath the whole time. So again, usually it's not an issue because we're doing all of this in less than 10 seconds, okay? But this is why this looks different than your retrospective gated study, because the X-ray tube is going on and off because the table has to move, okay? And this does take just a little bit longer because you have to use twice as many heartbeats to do this, okay? Now, why is a low heart rate necessary for a good CT study? What is the optimum heart rate? So why is a low heart rate necessary?
Besides less motion?
Less motion, right? But specifically where?
Like the diastolic phase affects the diastolic.
So what vessel becomes the limiting, as the heart rate gets faster and faster, what particular vessel becomes the limiting vessel to look at?
Aorta.
We're doing the coronary arteries.
RCA.
Yeah, the RCA. But what's the optimum heart rate?
66.
Yeah, around 60. If you could get, 55 to 60 is really golden. You probably shouldn't do it if you can't get the heart rate, less than 75 or 70. Probably should not even attempt it. But anyway, so here's a volume rendered view. So you can see how the heart is moving there in systole. But remember, we're reconstructing in diastole, right? And so in diastole, the only thing that might move is the atrium, okay, because of atrial contraction. So what happens is that as the heart rate gets faster, diastole gets shorter, okay? And so then the P wave creeps in to your reconstruction window. And so this is why you'll have atrial motion, and then the right coronary artery becomes the vessel that is most difficult to evaluate at the higher heart rates. And that's why you give beta blockers, right, to try to slow the heart rate down, so that gives you more time in diastole, and now your window where you scan is going to be free of the P wave there. And so you'll get less motion from the right coronary artery. You want the heart rate less than 70, but 60, 55 to 60 is really optimal to getting a really great CT study. And you can see here what happens to the diastolic time as the heart rate gets faster. It really shrinks very quickly. Diastolic time shrinks very quickly, so your window there, your optimal scanning window really gets small very fast as the heart rate goes up. And we've said that the vessel that is most difficult to evaluate is the right coronary artery, because remember, you're imaging in diastole, so the ventricle shouldn't be moving, but you will have atrial motion from the P wave as the heart rate gets faster and that gets into your reconstruction window. In terms of preparation of patients for cardiac CT, so since we want the heart rate low, it's important that patients are given instructions to have no caffeine before their CT exam. Our target heart rate, we're going for a heart rate ideally below 65 beats per minute. And to get that lower, we can give them metoprolol 50 to 100 milligrams 1 hour before the exam. If that doesn't work while they're on the CT table, they can be given metoprolol IV, 5 milligrams, Q5 minutes up to 15 milligrams. And if there's a contraindication to beta blockers, if the patient has asthma, they can be given verapamil to try to slow down the heart rate. Another thing that we can also do is give sublingual nitroglycerin while the patient is on the table to dilate the coronary arteries. So that will help get better images of the coronary arteries. Now, if you need to scan a patient with a higher heart rate, what options are available to scan such a patient? Well, one thing that we can do, remember we said that we needed 180 degrees of data in order to have enough data to generate an image, and that's what limits your temporal resolution. What we can do is something called multi-segment reconstruction. And here, what we will do is obtain 90 degrees of data from one heartbeat and 90 degrees of data from the adjacent heartbeat. And then the temporal resolution becomes the time it takes the gantry to rotate 90 degrees. So instead of the temporal resolution being 1/2 of the rotation time, now the temporal resolution is 1/4 of the rotation time. So this does improve the temporal resolution. So for patients with higher heart rates, this is a way to improve the temporal resolution. But the disadvantage of that is that the heartbeats have to be absolutely identical. So we take data from two continuous cardiac cycles, two adjacent cardiac cycles. We take 90 degrees of data from one and 90 degrees of data from the other. And so instead of a temporal resolution of 210 milliseconds, that can get us down to a temporal resolution of 105 milliseconds. Now you need a very regular rhythm because these two heartbeats have to be absolutely identical. And another disadvantage is that the resolution along the z-axis might be degraded somewhat. But here is one problem that can come up. So this is a patient, and we're taking 3 successive heartbeats here using cardiac cath, and we'll just draw the line going through here, the right coronary artery, for these 3 successive heartbeats. Now, when you superimpose all 3 of these, you see that they don't quite exactly overlap. So this is the problem, is that if you're taking data from more than one heartbeat, the heartbeats may not be absolutely identical, and then that can introduce artifacts in your imaging when you try multi-segment reconstruction. So it's not something you should attempt unless you absolutely have to for that particular patient. You would prefer to bring the heart rate down. So this is what happens with a low heart rate, very little motion artifact, and as the heart rate gets higher, then you get a lot of motion artifact, and it can make the study non-diagnostic. Also, arrhythmia gives you motion artifacts also in your images and can make the study non-diagnostic. Usually, we reconstruct our images when we're looking at the coronary arteries at 70% of the RR interval. But if you have more data than that, if you have data from other portions of the cardiac cycle, you may want to use that also in terms of reconstructing your data. So this was a retrospective CT scan in this case. So here's the right coronary artery here, and this is at 0% of the RR interval, 15% and 30%, and here 45%, 65, and 85. And you can see that as you look at the coronary artery, the right coronary artery, you seem to, in this particular case, you seem to get the best reconstruction at 30% of the RR interval. So if you have these different phases available, it's a good idea, if you don't get ideal images in the phase that you're initially looking at, to go back and look at other phases, especially for the right coronary artery, to see if getting other phases, reconstructing in other phases, gives you better images. So in this particular example, with the heart rate at 63, the right coronary artery at 50% of the RR interval, you can see that you get some very good reconstructions there, whereas at 70% of the RR interval, the right coronary artery looks blurrier. So you need to interact with the data in terms of the different cardiac phases. Now, that's for retrospective gating because you will have all of those phases available to you. If you're doing a prospective gated study, what we can do is add what is called padding. And this means that you go beyond the absolute time that is necessary to generate your images. So here, we're doing prospective gating at 75% of the RR interval, and we're adding more time, more tube-on time before and after. And so that means that we also have phases from here to here that are available for reconstruction. So we have some additional phases for reconstruction, even in this prospective gated CT scan. Of course, the disadvantage of that is that since the X-ray tube is on here, you are increasing the radiation dose, but you can use this as a safety factor. This is called padding. And so here's an example of that. So here at 75% of the RR interval here, we're looking at the right coronary artery, pretty decent reconstruction there at 75% of the RR interval. But we also had additional phases here. Here's 65% of the RR interval and 85% of the RR interval. So you can look at these different phases and then decide which one is best for looking at the particular vessel that you are interested in at the time. Now, the other thing that's important is that we want to do our images during the arterial phase. So as the contrast is going in, we want to time our acquisition for when the coronary arteries are maximally opacified. And another problem that you can also run into, because you have undiluted contrast that's coming down going into the right atrium, you can get streak artifacts from that, and that can streak right across your right coronary artery, as you see in this particular image, and can limit your interpretation. So this is not a real stenosis there of the coronary artery. That is streak artifact from the dense contrast in the right atrium. So there are things that we need to do to try to avoid that. So to optimize the acquisition in terms of the attenuation, in terms of getting the coronary arteries maximally opacified when we're scanning, we use bolus tracking, and GE calls it smart prep. So what we do is we localize the ascending aorta here, and then as we are giving the contrast, we obtain a series of low dose images at that particular level, and only at that level as the contrast is going in. And we have this region of interest that we can place over the vessel of interest, and it measures the attenuation there within that region of interest as the contrast is going into the vessel. Once it hits this particular threshold, and here we've chosen 150 Hounsfield units, once it hits that threshold, then it triggers the scanner to begin scanning. So the scanner then will go to its first position, and then will scan the complete heart. So this then optimizes the time from when you started giving the contrast and the delay to when you're going to start imaging the patient to make sure that the coronary arteries are maximally opacified. So as we acquire these images, we'll be acquiring usually from the top down as the contrast is going in, and you can see that this portion of the acquisition was obtained earlier than this portion. You can actually see the contrast washing out there of the right ventricle. Now, also to avoid the streaking of dense contrast from the right atrium onto the coronary artery, what we will do is after we give the initial bolus of contrast, we can either follow that with dilute contrast or with saline to try to wash out the right ventricle and dilute the contrast in the right ventricle. And so that then eliminates all of the streaking artifact that you can get onto the right coronary artery if you just had undilute dense contrast going into the right atrium. And so it makes it easier to visualize the right coronary artery. So here, when you don't use any kind of chaser, you get dense contrast in the right atrium. It can obscure the right coronary artery. Here, when you follow the initial contrast bolus just with saline, it really washes out the right-sided chambers, but then you don't have any anatomic definition there of your right-sided chambers. So this is a nice compromise here. So what you will do here is follow the initial dense contrast with dilute contrast, so that it still gives you some anatomic definition there of the right-sided chambers, the right atrium and the right ventricle, and it avoids the streaking artifact onto the right coronary artery. So this is probably the best way to do your cardiac imaging. And then the idea is to be able to generate your images and do these kind of nice multi-planar reformatted images. And these are the typical planes that we will reformat images to look in. So here we'll look at the left anterior descending coronary artery, kind of almost a two-chamber view, left atrium and left ventricle. And then here's a short axis view. Here's the left atrium as we watch the circumflex coronary artery going around there, the atrioventricular groove. And then we'll use also a short axis view to look at the right coronary artery. So here's the right coronary artery going around the right atrium. So these are the typical reformatted views that you would obtain when you're looking at these coronary arteries. And then of course, it is all of this is volumetric data. So you can go back and generate these volume rendered views, and you can also make the coronary arteries transparent. You get these nice pretty images. Although these are nice for looking at the overall anatomy, but for trying to evaluate actual stenosis, these are the views that you're going to be looking at when you're evaluating the coronary arteries. And then you can generate the views in all kinds of planes. So this is a three-chamber view or left ventricular outflow tract view. So here's the left atrium, left ventricle, here's the aorta, there's the anterior leaflet of the mitral valve, here's the posterior leaflet. So you get very nice resolution. You can see the papillary muscles, and you can actually see the chordate tendinite here going out towards the mitral valve. And then nice four-chamber view. So here you can look at the mitral valve and the tricuspid valve on that four-chamber view. And then from the four-chamber views, you can generate your short axis views. And so here we can generate a series of short axis views here going through the left ventricle, and we can see the left ventricle and the right ventricle on the same image. There's the interventricular septum. So these you would use if you had the data for functional analysis to look at wall motion and also to calculate functional data. So if you've done a retrospectively gated scan and you've obtained all of the cardiac phases, then usually we will reconstruct images at 10% increments of the RR interval. So we will have an image at 10%, 20%, 30%, so on, from 0 to 90. And then once you've done that, once you've generated all of those images, you can string the images together, and then you get this nice short axis view that plays like a movie, just like we did with MR. So you can look at wall motion, and then from the whole stack of images, you can also calculate functional data like ejection fractions, cardiac output, stroke volumes, etc., just like you do for MR. So the same thing is true for CT, only you have to make sure that you use retrospective gating if you're going to do that. And so here we have a nice three-dimensional view, volume rendered view there of the ventricle from this retrospectively gated CT study. Now you'll notice that the motion here, when we look at the motion of the heart, is not as smooth as the motion that we see when we're looking at cardiac MR. So why is that? Why is it that the motion here is not as smooth as the motion that you see when we've looked at cardiac MR studies? Any ideas? Notice it's a little bit jerky in the motion there. No thoughts on that? Well, what's better with cardiac MR as opposed to CT? It's the temporal resolution. So remember that with cardiac MR, your temporal resolution is about 50 milliseconds or so. Here on CT, we're on the order of 200 milliseconds. So because of that, as you're going from one phase to the other, the heart looks like it's jerking. So that temporal resolution is not as good with CT as it is with cardiac MR. Now, you can also do ventriculograms if you have the data. So there's a nice 4D ventriculogram here looking at the left ventricle, just like they would do in the cardiac cath lab. We can also do that with CT, just looking at the ventricle itself. Now, if I were to ask you what non-invasive, everybody talks about dose, what non-invasive cardiac imaging study has the highest radiation dose? What study would you guys think about? What's that? Sestamibbe. There's one with an even higher dose, although it's not done as much anymore, right? And that's Thallium, right? Thallium. So these are the radiation doses. So with 64 slice CT, if you do a full retrospective gated CT study, it's on the order of 12 to 16 millisieverts. We can get that down now, and we'll talk about how we do that to reduce it even more. But spec thallium is 25 millisieverts. A Sestamibbe scan is 12 millisieverts. So the Sestamibbe scans, the spec studies that they're always ordering on these cardiac patients, it's on the same order as far as radiation dose as a full-blown retrospective gated CT scan of the heart. Okay? Now, what can we do to reduce the radiation dose from coronary CT? If I gave you these three options and I said, which one of these three options would give you the smallest dose for a CT scan, which option would you guys pick if this was an exam question? Which it might very well turn out to be. Well, remember, this is retrospective gating. Even though you're doing tube current modulation, it's still retrospective gating. So you are getting a relatively higher dose there. So prospective gating would give you a lower dose because you're only going to be imaging during diastole. So the question is, between a 64 slice scanner and a 320 slice scanner, if you're doing a prospective gated study and you have a 320 slice scanner, I don't know how many of those people have, but which one of those would actually give you a lower dose? Yeah, why is that? In how many rotations? Well, if you have 320 slices, you should be able to cover the whole heart in one rotation, and that's the advantage, is that with a 320 slice scanner, you can cover the heart in one complete rotation, and so there are no wasted rotations. Every time the gantry rotates around, there's radiation that is wasted at the edge of the field. There's a term for that. What's the term for the wasted radiation? Penumbra. Right, penumbra is the term. So there's always wasted radiation every time the gantry rotates. So the less rotations you do, the more dose efficient the scan is going to be. Now, there are other things that we can also do to decrease the radiation dose, and we'll talk about these: tube current modulation, prospective gating, and iterative reconstruction. They say there's no such thing as a free lunch, but this is a free lunch, although you kind of have to pay up front a little bit more in terms of money, but it's still free in terms of radiation penalties. So with tube current modulation, the idea here is if you're going to do a retrospective gated study of the heart, and there's a study now that we do, cardiac imaging, where it's always retrospective gated and we get the whole heart cycle. What is that study? The TAVR studies. The studies that we do for imaging for TAVR, they're always retrospectively gated, and it goes through the whole heart cycle because you have to look at the aortic valve when it's open and closed, because you need to measure it in systole and diastole to be able to get the proper TAVR valve, the proper size of the TAVR valve that's going to fit that, okay? So when we're doing a full-blown retrospective study, what we can do is, since the diastole is when we're interested for the coronary arteries, we maximize the dose in diastole and we drop the dose in systole, because systole we're going to have noisier images anyway because it's systole, but there'll be a little bit more noisier because we're dropping the radiation dose. So this is called tube current modulation. Decrease the radiation dose during, maximize the dose in diastole, get very nice images, and you drop the dose here as you're getting closer to systole. You will have some noisier images, but you still have that information as far as cardiac cycle information. So we talked before about retrospective and prospective gating. With retrospective gating, the tube is only on during diastole, as opposed to prospective gating where the tube is on throughout. So here, of course, you're going to have a higher radiation dose, but you are going to have all of these additional phases that are available to you to reconstruct images in. So the problem with prospective gating is you do need a regular low heart rate. You need to be able to predict when the next heartbeat is going to occur in order to capture the same phase when the X-ray tube goes on. So as we look at the radiation doses, so for retrospective gating, if we leave the X-ray tube on full blast throughout the study, that's going to give you the most dose. With tube current modulation, you can still do retrospective gating, but we drop the dose here around systole, maximize the dose during diastole, so this significantly reduces the radiation dose. For prospective gating, the tube is only on here during diastole, so that really lowers the dose compared to retrospective gating. But if you have a multi-slice CT scanner on the order of 256 or 320 slices, then you can scan the entire heart in one heartbeat. And then there is no wasted radiation as the gantry rotates around. So this is the most dose-efficient scan that you can do. If you image the entire heart in one rotation, is the most dose-efficient scan that there is. Now let's talk a little bit about reconstruction. So most CT is done with filtered back projection, and it's a very simplified method of reconstruction, and computationally it's not very demanding, and so this is why this was originally used for CT, and up until near recently this was the preferred method for CT for image reconstruction. So how does this work? Well, I have some dense object over here, I take a projection like that, and from that projection you kind of get this shadow, and the idea is you just smear the shadow over your entire image. And then when you rotate and get another projection, now you have another shadow and you superimpose that onto this one. And the same thing as you go all the way around. So as you go all the way around, you project the data completely across the image, but where it intersects is where the object is. And so then when you superimpose all of these projections, you get some representation of the object. But here the disadvantage is, notice that there are these areas still of higher attenuation surrounding the object. So this is simple back projection, right? So for CT, we use what's called filtered back projection. And what that does is over here, they kind of drop the signal artificially. So they filter it to drop the signal just at the edges of the object. So when you do that and superimpose all of the data here, now you get a better representation of the object without that glow around the object where you have the regions of higher attenuation. So this is the principle of filtered back projection, and up until a few years ago, this is what was used in all of the reconstructions of your CTs because it was computationally not very demanding, right? But as computers advanced, we moved on to iterative reconstruction, and let's talk about what this is and how this works. So how this works is you take the object and you scan it, and now you have all of your raw data from the scanning and the different projections and your attenuation measurements. Then we apply filtered back projection, and that gives us an initial image. Now from this initial image, the software generates a virtual object. So it takes this virtual object and it models the actual physics of the CT scanner. So you can see how complicated this is getting, and it pretends to scan this object using your CT scanner, and then it generates virtual raw data. It takes this virtual raw data, compares it to the raw data that you actually obtained, and starts to modify this virtual object until the two of these come relatively close together, depending on what thresholds are chosen for that particular algorithm. And when they're close enough together, now you have a representation of what the real object is like, and that is your final image, right? So very computationally intensive. So this is why this was not available until computers got much faster more recently. The major advantage, though, of iterative reconstruction, what is the major advantage of iterative reconstruction? Why do we use it? What's its advantage? Why does it give you less radiation? Because in the end, what does this image have that we don't have with filtered back projection? This image has less noise. The major advantage of iterative reconstruction is it gives you less noise in your image, meaning that you can reduce the exposure factors up front to get diagnostic images just like you did with filtered back projection, but you can get them with less dose. So here's an example. This is filtered back projection of 150 MA, right? Here's filtered back projection 40 MA, so it's 1/3 of the dose, very noisy image. But if you use iterative reconstruction, so ACER is one method of iterative reconstruction, at 40 MA, which is less than 1/3 of the dose, you get an image here, right? But this image has comparable noise to your filtered back projection image. And then if we use this model-based iterative reconstruction, which is even better, now this image actually has less noise than your filtered back projection image, where you use more than 3 times the radiation dose. So what this means is that if you're using these reconstruction algorithms with filtered back projection, you will decrease the doses in your protocols up front. And so that is why we're able to do CT scanning now with less radiation dose, because of these filtered back projection reconstruction algorithms that are available. So what does this allow us to do? Well, with tube current modulation, you can get down to 50% reduction. With prospective gating, that's an 80% dose reduction. Iterative reconstruction, on top of that, we can add another 27%. What this means is that you can take a patient, and if they're not very big, if they're relatively thin, you can do a sub-millisievert diagnostic CT scan, 0.56 millisieverts for this CT scan, okay? So it's even less than what you usually do for a CT of the chest, right? So this is possible now with all of these methods that we have for reducing the radiation dose. Now, indications for coronary CTA, we've kind of covered a lot of this already. So all of this stuff, we talked about anomalous coronary arteries. If there is a question about anomalous coronary arteries, the imaging method of choice is coronary CT. So if that's a question that comes up, if in the cardiac cath lab they're questioning anomalous coronaries, the imaging study of choice, always coronary CT for anomalous coronary arteries, right? So interarterial is the bad one. We've talked about that before. So that's what you're looking for. You're looking for an interarterial course of the coronary arteries. For imaging coronary artery bypass grafts, if there's a question of patency of bypass grafts, again, CT is the method of choice. So CT is where we're going to go if we're looking at patency of bypass grafts. We've talked about internal mammary and saphenous vein bypass grafts in the last lecture. If we're looking for patency, this is what we want to do. So here's an internal mammary artery bypass graft, volume rendered imaging with CT. This is very good for showing you the volume rendered images, show you the course of the graft, and then you can go back and then do your multiplanar reconstructions to actually look at the grafts themselves once you've been able to localize them very nicely on your volume rendered images. Okay, here's an example of saphenous vein grafts here with CT, and you can see that how well you can see this graft. Here's the graft here, very nicely demonstrating the graft with CT. More examples of saphenous vein grafts here with CT. So if we're looking at bypass grafts, that's how we want to look at them. For stent patency, we can also look at stents, although it's a lot harder to actually look inside the stent. Usually what we look for is flow proximal and flow distal to the stent to be able to evaluate the stent. So here's an example of a stent. It's still a little bit difficult looking inside the stent, but we can see the flow proximal and distal to the stent there for that right coronary artery stent. Here's stents where we could actually see the occlusion of the stent from the CT images. You can see the thrombus there inside of the stent in this particular case. Okay. Now there are some limits to this. With current technology, your stent should probably be greater than or equal to 3 millimeters if you actually want to look at the inside of the stent to be able to say, how much disease do you have inside of the stent. So here with 0.25 millimeter resolution, which we haven't quite achieved yet with CT, you can get a very nice view of what the inside of that stent looks like, okay? Then if we're looking for coronary artery disease, especially non-calcified plaque, then the only way to see that is with a coronary CTA. Of course, you can see calcified plaques, you can see the calcifications without contrast, but you're not going to see the non-calcified plaque unless we give contrast. So here's an example of this patient had an equivocal stress test along the LAD distribution. So there was this calcified plaque here along the proximal LAD, which we can see with CT. And then with all of this multiplanar reformatting, we can demonstrate the plaque and the atherosclerotic plaque very nicely. And it is three-dimensional data. So you can go back and look at it and twist it around any way you want and look at to see how much does that plaque actually obstruct the lumen there, okay? And then you can take the vessel and actually straighten it out as if it's a piece of string. And you can do these reconstructions, and this is also three-dimensional, right? So we can twist it around and look at the plaque and see what is it doing to the lumen. So this gives you a lot of freedom in terms of how you want to look at these plaques and trying to judge how much encroachment there is on the lumen with these particular plaques. So here, for looking at individuals, this was a study that was done a while ago to show the actual effectiveness of CT. You can see that where CT is really strong anatomically is the negative predictive value. So the positive predictive value still can be a problem. In this particular study, I think they were using 50% stenosis, which is why the positive predictive value is not very good. But the negative predictive value of CT is excellent. So if your CT interpretation is that there is no significant obstruction, that is extremely reliable. The problem is if you decide that it's questionable or there is obstruction, the positive predictive value of CT is still an issue. So it has a very high negative predictive value, and it's best used in patients who have low to intermediate pretest probability for coronary artery disease. And the idea is to avoid invasive angiography. If we can say there's no significant stenosis with CT, then that patient does not need to go on to any other kind of workup, especially invasive workup. So you can also use it in patients at high risk for invasive angiography. So the limitations, we talked a little bit about the radiation dose already. Selected populations, if you have a patient who's unstable, you can't do a cardiac CT in that patient. They can do invasive angiography on unstable patients, but we can't do CT in those patients. And then we have limitations of arrhythmia, high heart rates, noise with obese patients, severely calcified vessels, grading of stenosis, and it's not a physiologic evaluation of the blood vessels. So we'll start with noise. So with obese patients, CT can limit CT. You get a lot of noise with these patients, and the only thing you can do is increase the radiation dose, but there is a limit to how high you can go, with the tubes and the way the tubes are rated. So with obese patients, they're patients with high BMIs, it's a problem. It's still an issue. Calcification of vessels. This is called blooming artifact, where when you have calcification of the vessel, it looks like the calcification takes up the whole vessel. So that's a problem with CT. So if you have very heavily calcified vessels on CT, that limits your evaluation to evaluate those vessels for stenosis. So we always do a non-contrast CT first, looking at the extent of calcification, and sometimes if you see that the vessels that you're most interested in are too heavily calcified, you may decide CT. Giving the contrast is not going to be worthwhile in that particular patient. Another problem is grading of stenosis. So stenosis is most accurately graded with cardiac cath. So if you compare our grading of stenosis with coronary CT, comparing how those same stenosis are graded with cardiac cath, you find that the correlation is not as good as you would want it to be. You see these dots are kind of falling all over the place. So when you look at this, what happens? So if we compare 64 slice CT with cardiac cath for grading of stenosis, so I give you a CT scan and I tell you to grade the stenosis as best you can. You say 30%, 35%, 42%, whatever numbers you come up with. And then we compare that with the cardiac cath for that particular patient. It turns out that the mean difference is plus or minus 15% between your actual numerical grading with coronary CT compared to the cardiac cath grading. And two standard deviations gets you plus or minus 30%. So what does this mean? This means that if you say there's a 50% stenosis on your coronary CT scan, when they do cardiac cath, that could really be anywhere between 20 to 80% stenosis on cardiac cath. So there's a large variability there in terms of, how accurate are you in grading the stenosis, which is why when we give an interpretation, we don't give an exact number, we try to give ranges of stenosis from CT. And this is why, because the correlation with cardiac cath is not very good. The problem seems to be that coronary CT tends to overestimate stenosis. And so there's a lot of false positives with CT that lowers the positive predictive value. So if the CT is negative, as we've said, that's a very reliable result. But if CT is positive, not so reliable. A lot of false positive with CT. And we'll talk about in the next lecture, some methods that we have to deal with that. It's also not a physiologic evaluation of the coronary arteries. So if you're looking at runoff from bypass grafts, if you're trying to look at collateral vessels, if you're looking at myocardial bridging, if you're looking at AV fistulas, we're only getting an image in one location in time when all of the vessels are maximally opacified, and that's all that you see. Whereas if they're doing a cardiac cath, they're actually looking at the flow dynamics as the contrast goes through the vessels. They can look at collateral vessels, they can look at AV fistulas in terms of, how do those fistulas fill? So that can be a limitation. So here's an example of a coronary fistula with CT, but notice that you're seeing all of the vessels at one time completely opacified. So you don't actually get to see in what direction the blood is flowing, what vessels are filling first and what vessels are filling later. So that can be a limitation of coronary CT. With bridging, although we can diagnose bridging with CT, remember that narrowing of the vessel tends to occur in systole, and unless you've done retrospective gated CT, which we tend not to do, you're not going to have that information to be able to see if the vessel is significantly narrowed during systole, even when you're looking at myocardial bridges with CT. Now, in the real world, again, this study was done a while ago, but it was, probably the first one to show the real effectiveness of CT for patients with chest pain. So this was 568 patients with chest pain who were considered at low risk, and the stenosis, their criteria for positive result was kind of conservative, greater than 50%. And they found very high sensitivity. Again, the positive predictive value is a problem, but the negative predictive value was 100%. So these are patients who are presenting to the emergency room. So patients present to the emergency room with chest pain, and they have they look at their risk factors. If they're very high risk, they're going to go to cardiac cath. But what do you do with the patients who are at lower risk, right? Used to be that, you wouldn't send those to cardiac cath. They would keep them from observation, do serial troponins, do a stress test the next day. And so that prolonged the workup for those patients. So here they did cardiac CT. It's one of the first studies to actually do cardiac CT in those patients. And they would discharge the patient. If the patient had a negative cardiac CT, the patient would be discharged. So 84% of this class of patients were safely discharged and with no deaths. So a lot of centers now offer this, where they will offer cardiac CT for patients in the emergency room who have chest pain. And if they have a negative cardiac CT for significant obstruction, those patients can be safely discharged from the emergency room. So this is a direction that cardiac CT is moving in. So what are the things that we need to remember is that a good CT scan requires a regular and controlled heart rate. So that's the first thing that you want to do, is you want to get the heart rate down less than 70. 65 or lower is really the optimum heart rate for a good CT scan. There's a very high negative predictive value. If you say there's no significant stenosis, that is very reliable, so that the probability that there is a significant lesion there is pretty much non-existent. The positive predictive value is a problem if we're looking anatomically. Now, in the next lecture, we'll talk about fractional flow reserve CT, which adds a physiological perspective also to CT, and this can improve the accuracy of CT in terms of the positive predictive value and the specificity of CT when we're looking for significant obstructive stenotic lesions. So CT can show us disease that is not visible on cardiac cath, because in cardiac cath, all we're looking at is the lumen, but we can actually see the plaque along the wall of the lumen that they may not see on coronary cath, on cardiac cath. Remember that your actual grading of stenosis can be off by plus or minus 30% at the extreme ranges. So that's why when you supply a grading, we talked about, we give a percentage and a range of grading, right? 25%, 25 to 50, et cetera, like that, when you're actually interpreting these studies. And we like to use these in the selected patients, so we're not going to use CT as a widespread screening method looking for coronary artery disease in the patient population because of the radiation dose.